Welcome to the AtoZrunning podcast, where we help runners thrive. I'm Andy.
And I am Zach, and up next, Dr. John Maskill joins us again to discuss one of the most underdiagnosed conditions and its solution. And after that, World of Running updates about records, fast people, and more. Welcome back. We are glad to be in your ear again, telling you wonderful things, and among them, answers to your questions. And we do that at the end of the month every month. And so if you have not submitted a question lately, do so by going to AtoZrunning.com/question, because then we can solve all your problems all at once.
Wouldn't that be nice? Well, we love connecting with you. We say it every week, but we really do. And it was really fun when I was running with Amanda. We saw Mike, who waved at me and said, "Hey, I'm listening to your podcast right now." So shout out to Mike, and also great job running that 20 miler that you were getting in on Thursday.
It's always a fun 4D experience when you are listening to us and then seeing us at the same time, and you're wondering to yourself, how do they manage such a feat? And of course, the answer is, when you're this amazing,
oh, goodness.
Many feats are not terribly difficult.
You're being crazy. But it is fun to see some of you in real life, and we can do that as we've been talking about at Rivertown Races. So that's coming up here really soon. You've been hearing
There's the big one.
Talking about it. It's going to be a lot of fun.
We're going to be there. We're going to be talking with you if you are there, and we're going to have stuff, and we're going to be running, and it's just, there's lots of fun things going to be happening on that day.
Which is what?
If you haven't signed up, it's April 22. It is 10% off still if you use code
Price
A to Z.
Increase, but
if you use code A to Z 10 for 10% off. You really gotta do this like right away. You've already basically missed all of the key deadlines. Now at this point, you're just procrastinating for no reason at all. So if you're gonna be in the West Michigan area, go to rivertownraces.com, use code A to Z 10, and get your 10% off.
Now on to the main topic. We have a returning guest this week. We had so much fun last time that we brought Dr. John Maskill on again. Dr. John Maskill specializes in comprehensive foot and ankle treatment and reconstruction at Orthopedic Associates of Michigan. His active involvement in research projects, publications, and presentations on a local, national, and international level puts him at the forefront in his field. As a resident teacher and mentor at the Grand Rapids Medical Education and Research Center, he is also committed to sharing that knowledge with the next generation of physicians, but he's also today sharing his knowledge with us. So that's exciting.
That he is doing, and then something he thoroughly enjoys doing, which is one of the reasons why we like having him on. And so if you missed the Achilles episode, it was great. It was poignant and practical. And what we're going to do here in this next conversation now is the second conversation we had with Dr. Maskill, where he basically said to us, like, if we're going to be talking about running stuff, we have to talk about chronic compartment syndrome. And here's why. And then he proceeded to make the case that I find to be just one of the most compelling cases you can make, which is this is a problem that a lot of people have, never know it, and it's debilitating. So they think, like, I'm not going to be able to run because of this problem, and don't necessarily get it diagnosed or diagnosed correctly. And with all of that, the solution is super easy and highly effective. So that's the part that, like, when he starts saying that to me, I'm like, okay, we got to talk to some runners about this. So the key here that you want to take away is you may or may not have or ever experience some of the things described here, but understanding the nature of how these things interact with each other informs some general day-to-day decisions we should all be making to avoid some of these problems. So we're going to listen to Dr. Maskill here drop some serious information, and we will all then be much the wiser for it. So let's get right to it. All right. Well, John, Dr. John Maskill, welcome back.
Yes, thank you.
Yeah, so we talked previously when you were on about Achilles and plantar fasciitis, and if anyone's listening who hasn't heard that episode, you got to go back and listen because it's good. It's good. But this one in particular, I'm really excited to talk about this topic before I even say what it is. Because as you were articulating things to me, the idea that you can say something like, we're going to have a surgery and you're going to be able to run again right away. As a matter of fact, I want you to run like a lot, so something like that. Okay, so you have a surgery and then you say we're going to run a lot. That's a good thing.
Yes.
And then also to be able to suggest that this is the kind of thing that is more common than people realize and yet not always something people identify.
Correct.
So it's kind of like, let's solve some mysteries.
Correct.
So that's what we've got in store
Yes.
for people here. So tell us, now I'm going to try to say it before you do, and then you can correct me if I say it wrong. We're talking about chronic and exertional compartment syndrome.
Yes. So for all of you people out there who love to Google, don't make the mistake of Googling acute compartment syndrome, because that is not what I'm talking about. So compartment syndrome, I'll just talk about what compartments are. So compartments, there are 4 compartments in your calf, okay? And there's the anterior compartment, which houses your extensors. They pull your foot up, okay? And that's typically right next to the tibia or the shin bone there. And then there's the lateral compartment, which primarily houses the peroneal tendons on the side, okay? And they help evert the foot, so they're used notoriously on uneven ground, so beach running, running on trails, etc. Those are the 2 compartments that are most frequently affected. Okay, with compartment syndrome that we're going to discuss. The 2 posterior compartments are in the back, are superficial, which means, right under the skin, so to speak, and that houses your Achilles complex, primarily, the gastrocnemius and soleus muscle. And then the deeper compartment syndrome, the deeper compartment is called it has all the flexors for your toes.
Right.
Okay. So those 4 compartments are wrapped by fascia. Okay. And fascia is, shall we say in layman's terms, is almost like a saran wrap. Okay. And it basically just, these compartments are where these muscles run, and they basically just keep them in their area. Okay. And it keeps them cylindrical. Okay. And the problem, though, is that the fascia is very unforgiving. And so the fascia, which wraps around these muscles, can actually be a constraint in certain instances, and it can actually not allow the muscle to get any bigger. Okay, so typically what ends up happening is, you will run, and the muscle will start to expand, and the muscle then gets engorged with blood. Okay, which makes that muscle bigger. Okay. And that's where you get you get the swelling in your muscles in your thighs and in your, and in your calf as you run. And what ends up happening is the fascia stops the expansion. And so it only has one place to go, and it expands like internally, or starts to fill every single space. And then what ends up happening to that is that the artery and the vein and even the nerve in certain instances that course through that particular compartment get squeezed off, and you end up losing blood flow to the muscle. And it comes about in the form of a cramp or even tingling, and it's very vague. It's very vague. So these patients have just vague leg pain at some point during their run, and it just won't go away unless they stop.
Because then it's not
the blood flow. The blood flow will decrease. The muscle actually will shrink, and now all of a sudden the blood is able to be returned to the muscle.
Yeah.
And the issue with runners in particular is a runner is notoriously healthy. Okay, so I don't have to worry about blood pressure issues in a runner usually. You guys work the heart just as much as you work every other muscle, right? And so when you have low blood pressure, you're the first person that's going to succumb to this because the pressure is low, okay? So if the pressure in the calf approaches that low number, it's very easy to actually pinch off the blood supply.
Right. So in that sense, our runner healthiness is kind of a detriment, or maybe not a detriment, but it exposes the issue more easily.
It does. Yep. And this is, it's not in every person. So this isn't something that every single person is at risk for.
Right.
This is dependent on anatomy. So someone's muscle might be bigger than another's. Someone's compartment might be smaller than the next person. Yeah. Or maybe their tissue doesn't expand as readily. Okay. Right? So we have, patients who are very hypermobile, or their tissue will give, even if it's they can hyperextend, or people will say I'm double jointed.
Sure.
Right?
Yeah.
Those are patients that the tissue is able to, they don't, have that tight tissue, so their tissues will expand pretty easily.
Sure.
Okay.
So it's less likely.
Okay. Yep. Yeah. And so it's not something that every runner has to deal with or worry about, but it is definitely present in a fair number of people, and it's, in my opinion, most notable in runners because they're constantly running, they're constantly expanding that muscle base, and then their blood pressure's low.
Yeah. Okay, well, and so you said then, John, that they may, it's the idea of like my leg hurts, but it's not really precise. I can't really put a finger on exactly why or where or how that pain is. But are there other things happening that kind of clue you into this may be the issue? Any other symptoms?
Yeah. So, the main issue is I get this classic patient that comes in and just says, I don't know what's going on. A lot of times we know kind of what's going on, or we know the structure that's affected. And this one, the patient just says, my leg hurts.
Yeah.
Only after I start doing exercise.
Yeah.
I can walk fine. I'm fine, but when I start to run, it starts to cramp up after I've been running maybe 1.25 miles. And they can almost pinpoint when it actually starts to, it starts to happen. And they're like, the only way that I can actually get this pain to stop is if I just stop.
Yeah.
And they say, Maskill, I've trained, I've done everything right. It wasn't doing this to me before. Yeah. And I just don't understand like what's happening to me. People think I'm crazy. My coach says there's nothing wrong with my leg, and there's no bruising. There's no, I didn't hurt myself. It just starts. And then all of a sudden it's not like I can't, I have to just run through it. The more I run, the more I have to stop.
Right.
Because I can't run through it because it gets worse.
Yeah. Well, so that's where the as the compressing is happening, as everything's squeezing, there's not like something you can do a little differently while you're running. I think about like when I've got something that's kind of like tight and pulling a little bit. If I just kind of like change my cadence a little, sometimes that helps. That's not going to matter here until you lower your blood pressure.
Yes.
Until you lower your heart rate.
Correct. And so and obviously there are different, if you have a day that, let's say you're nervous, right? What happens when we're nervous? Our blood pressure goes up, or we're stressed, right? You're going to do great on that day, right? You're going to do great on that day because you actually have more push in your artery. And so you might be able to make it farther that day before all of a sudden the pressure then overcomes the increase in blood pressure that you experienced. So
there's the kind of a sliding scale there potentially where,
whereas if you're stress free and you are doing great and you are, feeling athletic and,
really relaxed,
relaxed, well, then you might not be able to run hardly at all.
Yeah.
You know,
Wow.
and that's because, and you're like, well, I only made it to 0.75 miles and I don't understand why,
Yeah.
you know, and, you know, then you go to the urgent care, you get an x-ray and the x-rays are negative.
Yep.
And then you get an MRI. And what do you think the MRI is going to show? Absolutely nothing.
Right.
Because your muscles aren't affected. Your arteries and your nerves are completely fine. So it's only after you're exercising.
Yeah.
So people will call it exercise-induced compartment syndrome.
Sure.
Or chronic exertional compartment.
Okay. Yeah. That's where that. Okay.
Exertional compartment syndrome. Again, the key is not to you know, not to look up acute compartment syndrome, because that occurs in a trauma and it's a much quicker issue. It's the same type of issue. What happens in that situation is if you break your leg, you can actually fill those compartments up, and the blood flow from the fracture bleeding will actually pinch off. The pressure gets so high that no blood at any point can get through. And so that's basically one of the only orthopedic emergencies that we have. But the treatment is you got to open the leg up.
Yeah.
Otherwise you will actually lose the foot. But again, I want to make
That's not the
clear
same
that
thing.
that is not the same thing.
Okay. All right. Good. Well, okay. So you were just suggesting an X-ray is not going to give you anything. MRI is not going to give you anything. How do you know if this is what someone has, or do you have a way to know?
So I always like, you know, in runners, a tibial stress fracture, really we have to check that out.
Yeah.
Okay. Because so I do like to get an x-ray. Okay. And that's going to be negative. A stress fracture will also be negative.
Yeah.
And exertional compartment syndrome and stress fracture can look very similar-ish. Okay.
Yeah.
A stress fracture is going to hurt every time you kind of hop on it, though. Okay.
Right.
But you can aggravate it worse as you get running. But, you know, the more severe it gets, it usually starts up right away.
Okay.
Right. But people will kind of run through it, but you can keep running through it, really.
Right.
Okay. So I do like to rule out a stress fracture. And if the x-ray is negative, then I look for swelling inside the tibia on an MRI.
Yep.
Okay. But if all that is negative and there's nothing else crazy like a mass or anything like that which there never is, right?
Yeah.
Then I really start thinking compartment syndrome, especially in a runner who is exercising quite a bit, and they describe this, I'm fine the first couple of minutes and then bang, you know? So what we do is we actually check the pressures in your leg. Okay. And it's relatively benign, but there is a needle involved. We do actually numb you up to be able to accept the needle because it's a fairly big needle.
All right.
But once you do that, what we do is we actually inject just a little bit of saline inside the compartment. And then I've got a gauge that literally is very similar to a tire gauge, and it will read it. And I can tell with the pressure in the leg, and we measure each compartment.
Okay.
Okay. So the resting pressure is when you haven't run. Okay. So we would meet, and I'd have you lying flat on the bed, with your calf or with your ankle probably on a little pillow so that your calf can hang freely. So I'm not getting any pressure from the bed.
Yep.
And, we check the pressure in your compartments. If your compartment pressure is greater than 15, we call it millimeters of mercury. That's what we use. Yep. Then it's diagnosed right then and there, because your resting compartment pressure should be less than 15.
Yeah.
If it's normal, then that's probably fairly normal. Then I'd send you to my therapy department, which is right around the corner. And I would put you on a treadmill. Then I go back up to my office and you start running for however many minutes it takes for you to become symptomatic. So then you actually elicit the pain.
Yep.
And then they call me. I come down, get everything ready. We have everything kind of all set up. Then you run off the treadmill and you run into the room. Then you lay on the bed. Now we have a different scenario. Now I've got your muscles that are actually engorged, so to speak, and you're running, your blood pressure is down and everything, and then we inject, we do the actual pressure measurement, and at that point, the true definition is if it's greater than 30, or if it's within 30 of your diastolic pressure, which is the low number of your blood pressure.
Okay.
That means it's creeping way too close, especially if you're having the pain.
Yeah.
Okay. So what that means is if you have a diastolic blood pressure of 50, so let's say your 100/50 is your blood pressure.
Okay.
That means that just to keep the vein or the artery open, it's 50. It takes 50. Okay, that's the only thing it has to overcome. So if your pressure in your leg then is 25, then it's within 30, and in theory, it can start to clamp down on that artery. Okay.
Right.
If you have high blood pressure and you're 140/90, and I measure your pressure in your calf and it's 25, well, now we're, 90 minus 25.
Yeah.
Okay. So you're looking at a 65 millimeter mercury difference. So in theory, that's not compartment syndrome, right? Because there's not enough pressure there to really collapse the veins. So your blood should be getting through.
Yeah.
Okay.
Yeah.
Does that make sense?
That makes sense. So you're given a pressure gauge, pressure test.
Yes.
Because that's in the concept then is simply that there's not enough space for the things to do what they're supposed to do.
Correct.
And that's easy enough to test with pressure. Okay. You were telling me a story earlier, if you're willing to share, how this can be kind of crazy sometimes.
Yeah. So, I had a patient that very, very active runner, and, younger guy, out of college, and has been running his whole life. Okay. And, he just started developing pain in his leg over the course of time, and it got to the point where, he ran through it. But he really had to eventually just stop.
Yeah.
And it got to the point, because he really didn't see anybody. He got to the point then where, that he just couldn't even sleep with his leg on the bed.
Oh, no.
So he had to drop his foot off the bed.
Is that because of the pressure of the bed against his calf? Like why couldn't he have his leg on the bed?
Because, in hindsight, it was because he needed gravity to actually assist the blood through the actual.
He couldn't get the blood.
Could not get. So you need the downward push.
Yeah.
And this is very classic in any sort of artery type of problem.
Okay.
Okay. So if you have an artery that's clogged, it's very classic that so his primary care doctor, the first thing he thought of is like, you have a vascular issue, which he did. Right. And so he ended up, seeing a vascular surgeon, and turns out that he ended up having what they call an angiogram, where they actually they injected his veins with dye. And it just so happens that even while standing there, like, they couldn't get the dye through the artery past his knee.
Wow.
And so, in hindsight, what we found is that he had accrued so much muscle that the muscle essentially was pinching off the arterial blood supply, even at rest.
Even at rest. Wouldn't his feet be numb or something in a situation like that? Like,
yes. So he did have numbness. In fact, what actually brought him to the primary care physician was that he had a sore that wouldn't heal on his big toe.
Yep.
And runners get sores all the time. It's something that everyone deals with, and no problem. You just push through it, get it healed. But this would not heal.
Yeah.
So, the surgeon, the vascular surgeon, then said, I don't think the artery is really affected. Or, excuse me, not affected. It's not an arterial. It's not a problematic artery.
Yeah.
Okay. In other words, the artery really is normal. It's just not acting normal, because she thought first you need to really probably check the pressures in the leg first.
Yeah.
Right. So I was thrilled that person actually knew that was a possibility that could happen, especially, before trying to place a stent or something to increase the blood flow, right? Because that would be a great treatment for that.
Sure.
However, the right thing was recommended. And so the patient came in and saw me, and I just could not even believe it because I had not seen anyone with that severe of exertional compartment syndrome. So I said, you know what? We have to check we did all the things. X-ray, make sure there's no, nothing going on, bony wise. MRI, make sure you didn't have a mass, make sure everything looked fine. All that was negative.
Yep.
Everything looked great. So I did the compartment pressure test, and at rest, his compartments were literally like 40 plus. And it was baffling. Yikes. I was like, this is crazy. I've never seen anything that high. Usually a high resting one is 15 to 25, sure. Right? And this was like way high. So I said to him, I'm just curious. I just want to see you run. And you definitely have exertional compartment syndrome. You've had the angiogram. So, really what we need here is surgery at this point. But let's just see you run. And so he runs it's about 14 or 15 minutes, and he got it to the max. Okay. And he ran right into the room. I didn't, I looked at his foot, and just basically just like a anatomy lesson. There was no blood flow in this particular arterial distribution. So in other words, one artery was notoriously blocked, and it's in the anterior compartment. Okay. Yeah. The compartment that is most notably involved.
Yeah.
And literally it was just sheet white. And this was the same area that his sore was.
Right.
In. So it was not getting any blood flow.
Yep.
And so he was he was so sore, even just approaching him. And he's just like, oh, my leg is really aching.
Yeah.
So I went ahead and I said, okay, I don't have to stick you, but may I? Because I'm just curious to see what pressure we're at.
Yep.
And so I literally went to go re-inject and check him. And literally the pressure gauge just went bananas, and he actually shot back fluid and blood into my pressure gauge.
Like it couldn't even get it into his leg.
Like it went, I pushed it in, and he literally pushed it right back out. And I've never in my career seen that. And I've been taking compartment pressure measurements since before 2000, right?
Okay.
So I'm just like, this is crazy. So it was like well into the hundreds, and anyone with a diastolic pressure of anything over 100 is not well, right? But this is a healthy guy,
right?
So he literally closed off his entire arterial supply. Wow. So I said to him, you need to go to surgery. Yep. And normally this is not an urgent type thing, but I was so intrigued by this whole case that I was like, let's just get you on relatively quickly. Yeah. And so we ended up doing a surgical release, and the treatment for this is kind of brings us into that next the next topic. But the treatment for this is to actually surgically open all four compartments. Mm-hmm. So typically what that looks like, it's 2 incisions. And again, if you're looking at the acute compartment syndrome, okay, you'll see that the incisions are the entire length of the leg. Oh. Okay?
Yeah.
So the entire muscle needs to be opened up. Otherwise, the muscle will still die.
Yeah.
Right? So again, don't be freaked out by that on the internet. But the on a smaller scale, we still have to release the entire compartment. Mm-hmm. It's just that when you're talking about the acute compartment syndrome, the skin can be equally offensive as the fascia. So you actually have to open the skin.
Yeah.
Okay. In this scenario, we are not nearly to that degree. And so just releasing the fascia is plenty.
Okay.
Okay. So you make a small incision, and you can make it where you can see 2 compartments. So one incision releases 2, the other one releases 2.
Gotcha.
And you make a small incision into the fascia, and I kind of make a tunnel underneath the skin, and then I can physically see where my scissors are going, and then I just release it, just like I'm cutting Christmas paper.
Yeah.
Okay. And the nice thing is you don't cut muscle, and you don't, it's a long incision under the skin, but it's relatively pain-free because it's not it's not very nervated. Okay. So it doesn't have much in the way of nerve endings.
Yeah. Fascia's not,
Right.
That's what you're talking about specifically.
Exactly.
Okay.
The fascia itself. And that's what we're cutting.
Yeah.
So
right.
we're not cutting the muscle. We're just cutting the saran wrap, so to speak. Right. And when I did it for this person, it literally just popped right out of that compartment. And it was very healthy, viable muscle. But usually that happens when you have an acute compartment syndrome and you've got a lot of swelling from the trauma and you've got a severe amount of blood in there, right? But when you're talking chronic, it is literally just the size of the musculature that actually ends up determining that. Yeah. And so in this particular case, it did really want out.
Like you visibly saw the expanding.
I saw that muscle saying, "Thank you, Lord."
Whoa.
That I am free. I am finally free. Genie out of the bottle, and it's not going back in.
Wow.
And so then, what you do in the surgery to keep this, to keep this nice and open is I will actually take a small piece, probably about this big, out of the actual fascial layer, and to keep it from never being able to kind of officially close over again.
Yep.
And so after that is done, we close you back up. We put a wrap around your leg, essentially. Yep. And then, the treatment, the recovery really is bizarre, because what we want you to do is we want you to keep those compartments expanded so that your body can get used to the size. But more importantly, as you heal, we create scar tissue, right? That's how everything heals.
Yep.
So if you don't exercise and your compartment was this big to start with, and your body doesn't like that, right?
Yeah.
So we open it up and we've now created it this big. Okay.
Yep.
You want to keep it that big as long as you can so that the body knows, okay, I got to heal to here.
Yeah.
So if you sit at home and you're like, I'm going to take a couple of months off from running, then the tissue will come back to where it was originally. And it has an amazing ability to just, heal across, and it'll keep your compartments the same size, essentially. Right. So with this particular surgery, you can get a recurrence, and it can, that would be in the way of a failure, in that by the time people do start running and getting back to it, that their calf kind of healed tight again.
Yeah.
So to keep it open, I take a piece out so that it can't ever fully bridge back, especially in the two compartments that are the most notably problematic.
Okay, sure. So then what we've learned about this is it happens because as the muscles either, just getting stronger and the tissue's expanding, but as blood flow then engorges the muscle, that's when they're feeling the compartment. So your recommendation post-op is to run a lot, so they can get the blood flow in there to keep the compartment. I love that.
I know.
Great. As a runner,
it's
I
one
love
of
that.
those odd things where the runner gets to do actually what he loves to do, or she, and you want to keep those compartments as big as you would want them.
Yeah.
So there is, especially from the inside of the leg. Okay, so the most common compartments are on the outside of the leg, the lateral and anterior compartments.
That's where you're usually.
Yep.
Yeah. Okay.
And then on the inside of the leg is where the other incision is, and that affects the deep and the superficial compartments posteriorly.
Yep.
Okay, the deepest compartment, I actually have to take down a little bit of the soleus muscle.
Okay.
Because the soleus wraps and envelopes the deep posterior compartment. So I have to take that muscle down, and then I can actually see the compartment, and then I incise into it.
Yeah.
And you have to release the deep compartment fairly, several centimeters.
Okay.
You want to make sure it's released.
Yeah.
And just taking the muscle down can leave you crampy.
Sure.
That resolves.
Yep.
But it's something that's when I'm like, you just run the daylights through that pain if you can. There's like some cramping that goes on. But it's something that even just start with brisk walk, walk, get used to that pain a little bit and push, and then gradually start running. And, just really fill those compartments up. And it's a rewarding surgery because patients notoriously just love the concept that, wow, I've been struggling with this vague pain and now I'm better.
It's gone.
And it's gone. Yes.
I love it.
So yeah, it's fantastic.
So the one example, I'm assuming he was able to sleep with his foot on the bed again too, which
yeah, absolutely. So
probably just quality of life thing.
Yeah. So now that the compartments were released, and his muscle actually had room to breathe, all of a sudden, so the very next day, I get a phone call and I find out that for the first time in several months, he could sleep on his bed, and he was just the happiest guy around.
Yeah.
And, was like, I need to do the other side stat, and so we did, and he's doing fantastic.
That's awesome. Yeah. That's so good. So as I'm thinking about conversations with you in general, one of the things that I keep coming back to in my head here is it's probably important advice for runners that we should not ignore something for too long.
Right.
It seems to be the case that the longer we ignore it, the more likely it's not going to be an easy fix anymore, or as easy of a fix. So as these things go and the suggestions you're giving, talking to the right people and talking to anyone to get that conversation started is a big piece of it. And just being able to know what is going on here. We look at our problems as runners so often as it's just another thing. And eventually it gets bad enough that I got to just take time off and then I start again. But that doesn't necessarily mean that the problem's going to go away, especially with something like compartments issues that, doesn't really get better just because I'm not running. And so in this sense, I'm getting kind of like a good lesson myself from you. Just talking with you in general, John, that we shouldn't try to just ignore problems, certainly, but we also should not hesitate to talk to the medical people about the things that are going on. Talk to my doctor right away when I've got something, especially because there's a good chance my doctor knows about some of these kinds of things and can say, well, that's reminiscent of, maybe we should pursue something here.
Yeah.
So
I would say that the frustrating thing about exertional compartment syndrome is it is typically brought up by the patient because it is really a noticeable stop.
Yeah.
Right. Yeah. And especially to the athlete, right? So like I was saying before, it's something that you can't always run through, right? Or you start noticing that various things are occurring. And the frustrating thing about this diagnosis is that not a lot of us clinicians really know about it or really know what it is, right?
Yeah.
And so what typically happens is with this particular diagnosis, it's not like a tendonitis, and it's not like even a stress fracture. Maybe it starts like that, but all of a sudden it becomes more involved, right? So you start getting pain at kind of the certain time.
Yep.
Okay, and then if you push through it, some of them can push through it, as I was saying, and it you might be able to push through to a certain degree, and then all of a sudden it catches up with you again, and eventually it just gets worse. And patients even come in with feeling like they're clumsy,
right?
Because their foot doesn't work right, and maybe they don't have so much in the way of terrible pain. I mean, it's calf pain, which we all get when we run, but as it people can push through that, but then they start getting clumsy. And some people have even said, I feel like I want to trip,
Yeah. Right.
and they're like, I don't know. I just kind of feel like maybe that's just me running a lot and I'm just fatiguing.
Yeah.
Right. But it's one leg, or maybe it is two, but it's usually worse in one side.
Yeah.
And so you tell your primary care doctor and, it's probably a stress fracture, right? Not a bad idea. And, but why don't you just stop running?
Yep.
Give it a break. Well, you do that, and then you go back to running again and you've got a clumsy foot and you've got pain again, and it's just coming right back. Maybe by this time, you with your immobilization, your muscles shrank a little bit, so it takes longer to show up again, but it comes back. Right. And so, it's very common for me to see these patients after having seen, I'm their fourth or fifth opinion. They're frustrated. They think they're crazy because everything is negative. I had an MRI, it was negative. I had an X-ray and it was negative. I was treated for a stress fracture, but I still have the same pain. I don't understand this. And now I feel clumsy, what's going on. And, the clumsiness comes because the most frequently affected compartment, not only does, the artery go through there, but the nerve goes through there. And that actually assists with dorsiflexion of your foot. So if the pressure starts to get too much and you're able to keep running through it, then the next thing to go as the pressure increases, because it's only going to get higher, is the nerve starts to go.
Yep.
And so you can't pull your foot up as much. So they're describing it well, but we as clinicians just don't know about it. And so the frustrating thing is that you're talking to your primary care doctor and they don't see infinitely many number of runners.
Sure.
Right.
Yep.
So they don't necessarily really know or even have seen this diagnosis, and even orthopedists. Right. So I just happen to see a lot of feet. Right. And feet are attached to the calves. And so I'm fortunate to be able to actually, see it on a regular basis. So I know it.
Sure. Yep. That makes sense. Yeah.
Yep. And so they get very frustrated by it. And then finally, when you actually get and land to that right person and things just kind of start to make sense, it's overwhelmingly a good experience for the patient once you finally get the diagnosis.
Well, that's exactly it. That's what I was saying at the beginning, that it's one of those situations where it's like, I get that diagnosis and it's yes.
I know. Yeah.
I can have the thing solved, and that's good. That's good.
It is kind of crazy because when I first started practice 15 years ago, my office typically would put in our local newspaper diagnosis, treatment, and a treatment plan, and it would just be a FYI. This diagnosis, if you have this, this, and this, it can be treated like this. Come see us at Orthopedic Associates in Michigan, right? And so they did one on exertional compartment syndrome, okay, and for whatever reason, they sent all these patients to me, and this article triggered, I would say I describe them in terms of legs, probably 14 or 15 legs. Okay. Some of these people had bilaterals, right?
Okay. Yeah.
And when you're talking about this particular diagnosis, it is, this isn't something that walks in every day.
Right.
I mean, like, these are rare, more rare, but in the runner's world, it's not necessarily rare.
Yeah.
Okay.
Right.
But these people have had vague leg pain. And so it was just bizarre because in like literally probably 2 or 3 weeks, I had done more exertional compartment releases than anyone in my group.
Yeah.
So all of a sudden now I become this crazy expert on exertional compartment syndrome. And then since then, like, even competitive groups are sending me these referrals. And so I've just had a lot of experience with it for whatever reason. It's my quote niche, in foot and ankle surgery. So it's kind of weird, but that's why I've seen a lot of it. So I know I've seen a lot of variations of it.
Sure.
So,
Well, we'll try to do the same thing here then, because we got a large listenership in
Exactly.
West Michigan. So if you've got all the things described here and that vague leg pain and you haven't found a way to solve it, talk to the people at Orthopedics Association of Michigan.
That's right.
Call
That's
for
right.
John Maskill.
You got it. You got it. So it is, if you're experiencing that leg pain that you can't really describe, it's been frustrating, and you might even have nerve symptoms, and typically gets painful at maybe X miles, that's when I would definitely get checked.
All right.
So, and if you don't have a career to be a runner, you don't have to have your compartments released. But if you want to get past that, then that would be your next option. It's not a mandatory surgery, but to do what you guys love doing, running, is the only way through it.
Right. Well, there you go.
And the good news is the recovery is what you love doing.
And the recovery is the best part.
Yes, that's exactly right.
Love it. Pain-free.
So, you got it.
Well, if there's one specific takeaway that we have as we're listening to Dr. Maskill articulate this particular issue, among some of the other things we've talked with him about, it's that we as runners, we have this tendency, terrible, terrible thing that we do, where we have a pain, and it's not like totally debilitating, but it's pretty bad, and it comes and goes, or it's chronic, and it's never like knocking us out, or it is for a while, and then we rest a bit, and we come out. Anyway, the point is we got this thing. And we tend to just not try to fully address or investigate it. So it might be something where I go see my doctor, and my doctor says, it sounds like maybe this thing, get a little bit of PT, should be all right. The PT oftentimes is, in fact, great, so we're not denying that fact. But we have these problems, and they tend to just plague us. And what is often the case, and I've learned this more and more over the years talking with people like Dr. Maskill, is that there's usually something that's causing that problem that can be solved, or the problem itself is something that can be solved. And so when I hear that, I immediately think, why should I ever assume any problem is other than something that should and can be solved with the right kind of approach? And so my understanding with these things is everything has a potential solution, and we should try to find out what that is. Seek it out. That's kind of the key. And I appreciate it, as Dr. Maskill was talking about this one in particular, where he's like, it's often something that's misdiagnosed or just missed in diagnosis, because the nature of the problem is fairly unique and it's somewhat precise. And so this is not the kind of thing that everyone's going to have. Like a strained calf muscle is something that anyone's going to get at some point or another, right? But at the same time, there's a lot of these kinds of things that are just not necessarily obvious without pursuing and investigating further.
Right. And that's why we wanted to bring this kind of episode, so that we can become more aware, and we know that there could be solutions out there for us. So thank you to Dr. John Maskill for bringing all of your specialized knowledge to the A to Z Running podcast.
Right on. So now you know all the things you need to know, at least about that stuff. And speaking of getting to know more things, we have some interesting information for you now in the world of running. First, before we get into the world at large, some A to Z Runner updates of always note and excitement. Congrats to Craig on another marathon. So he's on a spree here. If you haven't noticed, we've been saying Craig's name a lot. He's doing like a marathon every month or more for a while here, and touring the country in the United States, as it were, trying to hit each state over an extended period of time. He's not trying to do them like all at once. But Craig just nailed another one, and a pretty strong effort at that.
Yeah, speaking of which, Erin ran an impromptu trail marathon, and she happened to win it. So
happened to? Is that how that works?
Well, she ran. She ran
win.
According to your advice there, Zach.
Well, without consulting me about whether she should run this race. Well, I suppose you could say that.
She took it very, very conservatively, and she feels great after the fact. But she was able to pick off some people in the final lap. It was a lap trail race, and it was muddy, and it was awesome. But it's her 14th state, so that was the other thing.
14th state, so she's doing some states.
She is. So congratulations to Erin on that marathon win.
keeping up the trail spree as well.
We've also had a lot of A to Z runners doing some really great things in training, including some unofficial PRs. So I want to give a shout out for that too. So
lots of good stuff.
Yeah, a lot of good stuff.
And if you want some of that good stuff to happen to you, you should definitely check out AtoZrunning.com/coaching for our coaching and training services.
Smooth as Zach.
Speaking of fast people, let's talk about Hillary Bohr breaking a 40-year-old American record.
Which is really cool because it hits a little bit close to home here because Greg Meyer from Grand Rapids, Michigan area, he's the one who held that 40-year-old American record in the 10-mile
Officially
run.
held
Yeah.
it. Yeah, the 10-mile record.
It's a 10-mile record. It was unusually cold temps and strong winds at the Cherry Blossom 10-miler. So that was kind of a unique time and place to be breaking a record, but Hillary Bohr did such a thing, and he ended up beating the previous record by 2 seconds.
Wow.
Yep, he ran 46:11.
Okay.
And this is also the 10-mile road racing championships, and that one does move around because it wasn't there last year.
Most of the road championships move around, yeah.
So Hillary Bohr actually ran faster than that time last year in the 10-mile road racing championships, but it was somewhere else that wasn't eligible to get this record.
Yeah, so as road racing records go, the course matters immensely because there's a lot of reasons why a course won't be records legal.
Right.
You've actually heard many times over the years of someone breaking a road record but not actually getting the official record because of things like that. Or they did it in a different distance, like a half marathon. They broke the 10-mile record, but there wasn't a timing mat at 10 miles that was official and sanctioned, and so they don't get the record.
Or too much downhill or
all the things. Yeah.
all the things. Yep.
Well, so nice work to Hillary Bohr,
Yes.
finally knocking that one off. That's impressive.
And getting the USATF 10-mile road racing championship
Why
win.
not?
Yep,
Take
why
a title
not?
while you're at it.
On the women's side for the USATF 10-mile championships, Sarah Hall was the winner, and she now has a total of 12 national titles,
Well,
including that one.
4 of them, in fact, at 10-mile races.
At the 10-mile distance.
She's
So
really good at the 10-mile.
She is.
Wow.
In 2017, 2018, 2019, and now in 2023.
Well, that was a nice little spree she had there. 3 years running.
Yeah, it's fantastic.
Cool.
So she was second in the entire race because this is also the open race, the Cherry Blossom 10-miler, to Sarah Chilenge of Uganda. Hillary Bohr, I should mention, was second to Sige Kidanu. And so both of them were second in their races, but first in the USATF championship. Okay. And then I did want to shout out Carrie Verdon, who's a previous podcast guest. She was 7th for the USATF. Yep, for the championship race.
Right on. Okay. Well, speaking of records and fast people running them, Eilish McColgan does a lot of that.
She does a lot of that lately. Yep. So she broke yet another record. Well, it was her own, but she beat it by a significant margin. So at the Berlin half, she ran 105.43 to take 43 seconds off her own British record. Yeah.
There aren't that many people in the world running under 106 in a half marathon.
Not very many men even running under 106.
I'm saying people in the world. That's so fast.
It is really fast. And she was the overall women's winner. It was a pretty fast day because there was actually 3 men who were under 60 minutes, which is a big barrier to break. Yep. And this is a really promising show of fitness before Eilish McColgan's marathon debut coming up in London.
In London. So all the talk, Boston and London have the strongest fields that they've had maybe ever. And so now there's this debate of like which one's got a stronger field and such. And I don't really care much about that kind of a debate.
I'm glad
However,
that they're both strong, so it'd
they're
be fun,
both strong.
fun to
It's
watch
gonna-
both of them.
Fun stuff, including McColgan making a debut in London. She was going to do that previously, and that was injury or something that she decided to withdraw. But here she comes, and
Here
we'll
she
see.
comes.
With
Very quickly she comes.
Yeah, all the signs point to an interesting race in London. Well, let's talk about interesting races for a moment, because our third element here is jumping across entirely around the world to Australia and the Australian Outdoor Track and Field Championships. So I'm not quite sure. Someone needs to help me understand, if they know better, why, in particular, this year, a lot of the big names, the big Australian names, did not run in the championships. Now, I know they actually do that quite a bit, especially if they have already give a bye qualification for like an auto qualification for the World Championships, then they often won't run the Australian champs. So this is, again, we've talked about this in the past. Australia, like most countries in the world, will select most of their World Championship qualifiers arbitrarily. It's not arbitrarily, but it's in arbitration as opposed to from their championship races. So they might give like the first person in the championship race a seat if they also have the world rankings high enough. But most of the other ones are just selected.
May I guess? May I make a
What are you guessing?
guess why they didn't come? I think because we talked about how the ranking system works, and there's not many races that qualify to get points in Australia. So the travel cost, physically, time-wise, I'm sure even financially, takes a toll on these elite level Australian athletes. So that's my guess as to why some of them don't come, is because they're not training in Australia.
Well, and they're not racing there either. The good races are in Europe and some in the USA, which is where they all tend to be.
So that's my guess.
Yeah, I think you're right. So, in that being the case here, we still had a really interesting experience watching the 1,500 meters.
We did watch it. It was fun.
For the men's 1,500 meters. So here's the reason particularly why I was very interested in this one, because on the Australian scene, there is a 16-year-old who is a name that you should know and watch. His name is Cameron Myers. He is, again, 16, and he is besting Jakob Ingebrigtsen's age group records.
Which is saying something because Jakob Ingebrigtsen has most of the age
group records, especially for the middle long distances, like 1,500 through 5,000. So here's what Cam Myers did earlier in February. If you weren't familiar, he ran 3:55 mile, which is faster than Jakob Ingebrigtsen's 3:58 mile at the time record for the age group. So now that's at 16 years of age. Here's the crazy thing. Cam Myers just missed by 9 days being the youngest person ever to run sub-4 in the mile.
What?
Yeah. So if he had done that 2 weeks earlier, he would have been the youngest person ever to run sub-4. Still,
6 days?
Ingebrigtsen still holds that, though, because he was 9 days younger when he did it.
Okay.
But Cam Myers ran 3 seconds faster, though.
Whoa.
So
3 seconds is a lot in that distance.
He chopped time off of Ingebrigtsen's time.
So impressive.
Now, continuing that, at the Australian Championships, he then showed his stuff again in this 1,500 meters. First of all, by commanding the race as a 16-year-old in a race with some veterans. I mean, there were some serious competitors here in this field, and he took control pretty early in the race and then kind of just made the race what he wanted it to be, which is just incredible. The patience and the strength of mind to do that and stay composed.
I mean, that takes a lot of confidence to lead a race like that.
Oh, yeah. So he did that, and it worked out fairly well for him because what ended up happening is he ended up taking second. Unfortunately, Callum Davies beat him in the kick, and it was a very impressive kick at that.
Yeah, he ran a smart race.
Michael Ramsden, who is probably the favorite in some people's eyes, Callum Davies is definitely not a name unheard in that scene. But so Ramsden had the strong lead with like 150, 200 meters. He took the lead and was charging down the straight, but Davies and Myers caught him right near the line. Myers in a close second to Davies. So here's what happens. Cam Myers runs then in doing that 3:38 for the 1,500, which is now another age group record over Ingebrigtsen's previous record. And this time he didn't chop tons of time off. It was about a second or so. But what this amounts to is now he holds the 16-year-old records for the 1,500, the mile, and the 3,000, which he also set earlier this year. And so Cam Myers is just knocking off one at a time every Jakob Ingebrigtsen age group record that he can. And I am thrilled to see how this continues to go.
And Jakob Ingebrigtsen has world records, so that's how we know. And he has so many medals to prove that he's become one of the greatest of all time. But to have this young man, Cam Myers, clipping off some of his age group records is saying something about Cam Myers' potential.
It kind of shows you that there's there's, these are once in generation athletes that people often say. Well, not quite so much, because
A few.
there's a couple in the same generation here doing the same thing. Yeah, it's just fun. It's fun. All right, so watch Cam Myers. Tune into that Australian and his amazing feats, because I don't think we're done with them yet.
I don't think so either. Well, speaking of not being done, well, we're done with this episode,
Well,
but we're not done with the podcast. So
speaking of not being done,
you haven't
we're done. Wait, that's not right.
if you haven't subscribed, please subscribe. We're going to be giving out more content. We've been doing this now for, 3 years?
Giving out content. Is that what we do? We give out content.
We will be producing weekly content about running. So if you are looking for that, please subscribe. And again, we love to meet you in real life too. So say hello when you see us, please.
And come to Rivertown Races on April 22, so you can in fact guarantee that you will see us. That'll be lots of fun. With that, thanks again for listening, and we will talk to you again next week.